Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everybody. And all you Attitude listeners, I'm Susan Kaufman here for Attitude Magazine. Thanks so much for joining us for this week's ADHD Experts broadcast on the topic of inattentive ADHD. This is podcast episode 362. If you are wondering what exactly inattentive ADHD is, how it differs from the classic hyperactive ADHD, and why it's often misdiagnosed and how it's treated, then I think you're going to find today's presentation by Dr. Thomas Brown and Dr. Ryan Kennedy pretty fascinating. I know I'm looking forward to it. Before I hand the microphone over to Dr. Brown and to Dr. Kennedy, I just want to tell you a few housekeeping items. For those of you who are tuned into the live webinar, you may download the slides right now by clicking on the event resources section of your screen. If you are interested in the certificate of attendance option, wait for about an hour after the end of the broadcast for an email that you'll receive with instructions. Some of you may be listening to this in podcast mode. If so, please visit attitudemag.com and search podcast 362, that's 362, to find the accompanying slides if you're interested, or the webinar replay if you'd like to see a video. And also, you have access to the certificate of attendance option. On a personal note, let me just say that if you support the work that we do every day at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for a subscription to Attitude Magazine for your family, to share with a teacher, or for anyone and a loved one who might benefit from greater ADHD understanding. We are really grateful for your support. And I would like to thank the sponsor of this week's Attitude webinar, to whom we are also grateful, Play Attention. For over 25 years, Play Attention has been helping children and adults thrive and succeed at school, at home, and work, enhancing brain function and focus. With their NASA-inspired technology and cognitive exercises, Play Attention improves executive function and self-regulation. Each program, interestingly, now includes a lifetime membership and a personal executive function coach to help you customize the plan as you go along. So we really urge you to go to playattention.com/free-consult to schedule a free one-on-one consultation and discuss a customized executive function training plan just for you. The number is 800-788-6786. and the URL www.playattention.com. So take advantage of that terrific offer. Just a brief bio of our expert speakers. Thomas Brown should be well known to all Attitude listeners. He's one of the foremost experts in the field, a clinical psychologist with a Ph.D. from Yale University, where he served on the clinical faculty at the Yale School of Medicine for over 20 years, while also running a clinic for children and adults with ADHD and their related problems. He's an elected fellow of the American Psychological Association and the American Society for Clinical Child and Adolescent Psychology. He is the author of 7 books, each one of them absolutely a must read, just naming a couple: Smart But Stuck, Emotions in Teens and Adults with ADHD, Outside the Box, a great overview of ADHD, Rethinking ADD and ADHD in Children and Adults, and forthcoming, ADHD and Asperger's Symptoms in Smart Kids and Adults, which should be really well received. We're happy to welcome Ryan Kennedy today. He holds a Doctor of Nursing practice, and he's collaborated with Dr. Brown for over 12 years in all aspects of research, publications, and clinical practice. He's an associate director of the Brown Clinic for Attention and Related Disorders, where he specializes in assessment, behavioral, and psychopharmacological treatments for children and adults. Let me just note that the clinic's website is www.brownadhdclinic.com. Thank you so much for joining us today, Dr. Brown and Kennedy. We are really so pleased to have you. We know how much time this takes, and we're grateful for it. With that, I will turn it over to you.
Thanks very much, Susan. It's a pleasure to be with you. And also to be talking about the inattention aspect of ADHD. A lot of people, I think, overlook the fact that though this disorder, which we now call ADHD, has been recognized for a long time. It was first written about in the medical literature in 1902. in English. But the fact is that the emphasis was for years, decades, on little boys who couldn't sit still, wouldn't shut up, and are driving everybody nuts. However, the diagnostic criteria for ADHD for a number of years now have included a list of what you see on this slide, these 9 symptoms that have to do with difficulty paying attention to details and sustaining focus and attention, difficulty with organizing, and so forth. And this is the scope of what we're talking about when we talk about the inattention with ADHD. It's not a matter of not being able to focus on one thing. We'll talk about that in a moment. But let's take a look at some of the things that are included in this. We often talk about the ADHD as a problem with focus, but many people think of, oh, that means I should be able to zero in on one thing and really stay locked on it. Actually, it's not so much focus as in hold the camera still to take a picture. It's much more like focus on your driving. If you think about what you do when you're driving, you're not gluing your eyes to the bumper of the car in front of you. You're watching what they're doing. But you're also checking your rear view mirror and your side view mirror. You're also noticing a truck is backing out of a driveway. You're also noticing that the stoplight down the street is turning from green to red, and you got to get your foot off the accelerator and move it toward the brake. You have to ignore some of the things that might be going on alongside you as you're going along. And remember this and ignore that and be able to keep in mind what it is you've got to do to drive the car safely. And it's that sort of notion of being able to utilize these various aspects of paying attention and focus that constitute the essence of ADHD. And the term that we've been using to talk about this for a while now is executive functions. And what we mean is it's a wide range of central control processes of the brain that serve to connect and then to be able to prioritize and integrate our cognitive functions for us moment by moment. And it's a very dynamic set of processes. And the metaphor that I often use for thinking about this is you picture a symphony orchestra where all the musicians are soloist quality, really very good at playing their instruments, regardless of how good they may be. If you don't have a conductor who can select what they're going to play and get each one to play his or her specific part in the same piece at the same time and keep them on time and bring them in and bring in the strings and then fade them out and bring in the brass and organize them and start them and stop them. Without a good conductor, you don't get very good music out of a symphony. The problems in brain are not tied to one little part of the brain like one instrument in an orchestra. It has to do, these executive functions are like the conductor of the brain's symphony. Now, in just a moment, I'm going to show you a picture which some of you may already have seen a lot of times, but this is the model of executive functions that I developed over the course of a number of years of talking with people of ADHD and trying to learn what their strengths were and what they were struggling with. And before I get into talking about the model, let me emphasize 2 things. One is this is dimensional. This is not an all or nothing thing. It's not like pregnancy. You are pregnant or you're not pregnant. There's nothing in between. It's more something that's it's like a spectrum. It's sort of like depression. Everybody gets bummed out once in a while, but just because somebody's unhappy for a couple of days does not mean we're diagnosed them as clinically depressed. It's only when the depressive symptoms are persistent and making a lot of trouble for me to say, yeah, that's a depression. We ought to do something about it. And in the same way, all of these things that I'm going to be talking about are things everybody has trouble with sometimes. The question is, how much trouble? To what extent does it really get in the way? Now, the situational variability, the second bullet on this slide, is something that I'll talk about in a little more detail later. But let me just mention right now, one of the things you'll think about as we talk about this, hopefully, is that all of the things I'm describing are things everybody has trouble with sometimes. And that for everybody I've ever seen who has ADD has a few things they can do where they've got no trouble with these things, even though they may have a lot of trouble with them in a lot of other things they do, which makes it look like it's a willpower problem when it really isn't. But more about that in a moment. This is the model. There are 6 clusters. This is just one of a number of different models that exist for understanding ADHD, but this is the way I think about the combinations of functions that we call the executive functions. And these are the things that typically people with ADHD will tell you they have trouble with. Now, if you take a look at the terms at the bottom, activation, focus, effort, and so forth, these make it sound perhaps like it's all one thing, but the fact is that you could think about this better as sort of baskets of related cognitive functions. And then the other thing that needs to be said is that these are not, though we have little boxes that make it seem like they're quite separate, the fact is these aspects of brain operate in an integrated way, very dynamically. Third point, they operate mostly unconsciously, not in the old psychoanalytic sense of unconscious being repressed, but in the fact that they happen so fast with automaticity that we don't usually stop and think about them very much unless we're dealing with something that's unfamiliar or that's really stressing us out. Now, I'd like to take a few minutes just to talk about each one of these separate components, and then we'll go on from there, because I think it's important to look at the dynamics. One part of it people with ADHD struggle with is being able to get organized and prioritize, decide which things are most important to do now. And sometimes it's a matter of organizing materials, and sometimes it's just sort of prioritizing the tasks and then figuring out how long it's going to take you and then getting started. The second cluster talks about focus, but it doesn't mean locking on to just one thing. It's being able to sustain the focus when you need to, but then also being able to deal with the distractions that come sometimes from what's around us and sometimes with things that are in our head. And then an example of this, of course, would be reading. When you talk with people about ADHD and reading, often what they'll tell you is, I understand the words perfectly well when I read them, but they don't stick in my head. And so I turn the page and realize that even though I read and understood it, it didn't really get into my head. And so I got to go back and read the damn thing over again. These are examples of the difficulties around focusing, shifting attention, and then sustaining attention when you've got multiple things to deal with. This next cluster is talking about several different things that belong together. One has to do with being able to regulate. People with ADHD often have difficulty getting to sleep at night. They'll often say, I stay up a lot later than I really want to or should. But they also sometimes have trouble waking up in the morning and being able to stay alert during the day, even if they've had a decent night's sleep. Often there's difficulty in sustaining interest and effort. And then another thing, which is not much talked about, but it's very much a part of what many people struggle with, is that when people with ADHD are trying to write essays or even long emails or something like that, very often they find themselves having a hard time cranking it out, that it just takes a lot longer sometimes for them to take ideas, which might be very good ideas, and be able to put them into sentences and paragraphs. The fourth of the 6 clusters, again, this is one that we're going to be talking about, but the fact is that this is not officially a part of the DSM-4 or DSM-5 criteria, and that is difficulties with managing frustration and modulating emotions. That's an important part of ADHD for most everybody I've ever known with it. And the difficulty is that sometimes the frustration a person feels, or the hurt feelings they have, or the desire they have to get something that they want to get and they need to get it now, or their worries, invade their consciousness like a computer virus that just gobbles up all the space. It's very hard for them to shift focus. Memory. The biggest problem for many people with ADHD have very good memory for long-term stuff, but a lot of difficulty with their memory for remembering what they just were about to do when they went into the room to get something, or what they were going to say to somebody else, or what somebody else just said to them, as well as difficulty with prospective memory, with being able to remember that I wanted to stop and pick up some milk on the way home from work today because I'm going to need it for dinner. And the other factor is that this is a short-term working memory for the most part. It's not so much remembering things from a long time ago. Many times those are tasks that they can do easily. But it does include difficulty sometimes in being able to pull what you need out of the files at the time you need it. And then the sixth and final cluster is not just being hyperactive or impulsive. Many people with ADD are not hyper at all. And sometimes the problem is being able to get themselves cranked up to get going. But there are some people who, even as adults, have difficulty controlling, slowing themselves down when they need to slow down and speeding up when they need to speed up to get something done. And being able to size up, monitor the action to size up how well it's going. And at the same time, modifying one's actions to fit the situation so that you don't end up doing something that later you're going to have to say, oh my God, why did I do that? But now these six clusters, they work together. But the puzzle, what I think of as a central mystery of ADHD is this issue of situational variability, because what happens is every person I have ever seen who has ADD has a few things they can do where they have no difficulty focusing, no difficulty sustaining their efforts. But at the same time, they're not able to focus as well for others. And usually it's either something that's really interesting to them or something where they feel like if they don't take care of this right now, something they do not want to see happen is going to happen fast. Now, there are two hypotheses about this that many people think, oh, that's just a willpower problem. You just need to try harder. But I had a college kid one time who he said, I've got a sexual example for you for what it's like to have ADD. He's had incident. I use the term ADD and ADHD interchangeably in case you hadn't noticed. But this college student said, having ADHD is like having erectile dysfunction of the mind. If the task you're trying to do is something that turns you on, you're up for it and you can perform. But if it's not something that really turns you on, if it's not something you're really interested in, you can't get it up. If you can't get it up, you're not going to be able to perform. And in that situation, it doesn't matter how much you may say to yourself, I need to, I ought to, I should. You can't make it happen. It's simply not a willpower kind of thing. So what we're talking about is something that has a lot to do with motivation, but it's very specific to other people, and it's often unconscious processes. And what you're doing, it makes a difference who you're with. This example is from a time my wife and I were flying across the Atlantic. I had to go give some talks in Europe, and I was on a diet, and the flight attendant was passing out cookies, chocolate chip cookies they had just baked. And I knew that was coming, but I was on the diet, and I figured, well, my wife is with me. I don't want to have to listen to her tell me, well, you're doing so well on your diet and so forth. And I looked and saw my wife was asleep beside me. And I think you could probably know what happened. And they offered me the cookie. I got one for myself and one for her and ate them both. Emotions tend to shift according to context. Like a kid who works very hard to get every term paper in on time may not give a damn about his paper because his girlfriend just broke up with him. That's all he can think about. Or somebody else who you could care less most of the time about getting schoolwork done may get really interested if they find out that they're going to lose their athletic eligibility if they don't get some grades up a little bit more than they are right now. So let's talk just a little bit about what's going on in the brain, because I think it's really important for understanding the role of medication for helping with ADHD. Everybody's brain has in it 100 billion neurons. These are so tiny that they're about 2/3 of the diameter of a human hair. And each one of them is interacting with over 1,000 others in these very complex systems that keep changing. They're working with low voltage electrical impulses to send signals through the brain, and they have to jump across gaps. And I'm just going to run you through a set of this is how complicated it looks, and then some, if you check it out under a microscope. But the fact is the action is at the synapse. That all these networks, the connection points from one neuron to another don't actually touch each other. This is a single neuron, and here's where it gathers the information, and here's where it's communicating it. And what happened, it has to happen to get that electrical impulse from one place to another, from one neuron to another, is it needs to release, you need a release of a chemical that allows it to jump. And so it's made here in the tip of the sending side, and then there are receptors on the other side. And this is a space thinner than a piece of tissue paper. So the electrical charge comes here, And then you get the chemical release as it zips in. That sends the message across, hits the receptors. And then after the message goes zipping on, if it comes in strong enough. Now, most people with ADD don't have any trouble with strong signals for things they're really interested in or where they feel like they've got a gun to their head. And they don't want to see things happen the way they might happen if they don't take care of this right now. However, a lot of people with ADD have a hard time getting the strong enough signals in on things that are not really that interesting to them. And then what happens is that there are transporter cells, full protein cells here, and they have a job. They have to suck back up the chemical that's been released very rapidly so you're ready for the next signal that's coming through. So, and this is happening in 1 millisecond. You can get 12 messages across. It's that fast. Now, the thing to know about this is that a lot of people run into difficulty with ADHD because what they find is that the medication, which basically is doing one thing, it slows the reuptake so it doesn't happen too fast, and increases the release for some other medicines as well. If a person taking this medicine is feeling too wired during the time the medicine's working for them, or too crabby or too serious, chances are, and you sort of lose your spark, you don't feel much like talking to people. If that's happening during this time when the medicine's supposed to be active, chances are the dose may be a little high. However, if you're not having those problems during the time the medicine's supposed to be active, but you do find it happening later in the day as the medicine's supposed to be wearing off, that's a completely different problem. That's what we call a rebound. And what it means is not that the dose is too high, because that you would have known here. It happens, it drops too fast. Okay, now at this time, Dr. Kennedy, my colleague, is going to give you a few specific examples of things that relate to the medication and people's experience with it. Dr. Kennedy.
Okay, thank you, Dr. Brown. So these next 5 case studies I'm going to share, I have changed the names and information about patients, but these are real stories and common problems for a lot of people with inattention and ADHD. And my first patient is Cheryl. She's at 50 years old with 3 kids. And she had said to me, I've had ADHD all my life, but menopause has made my medication worse. I was really puzzled by this and trying to figure out, had she had ADHD all her life? Is menopause actually impairing her executive functions? And she had trials of medication in the past before she had seen me. So I had to go through a lot of her history to figure out information about how she responded to this medicine and this one and that one. And I was getting sort of the same flavor from each of them, which is she takes it in the morning, but it doesn't work until way later in the day. And I was sort of puzzled by this of, is the medication dose too low? Is she metabolizing this too slow? Is there an issue with other medications interfering? And what it came down to through this whole trial and error process over several months was a simple switch to a brand name medication from a generic tablet to the immediate release that she was taking 3 times a day. It surprised me, but it's sort of an exception, but it happens once in a while.
Okay,
flip this back over.
I'd just like to add a little bit related to this menopause issue. And that is that there are a lot of people, a lot of doctors don't even understand this. But the fact is, a lot of the women, girls and women that we see who have ADHD report, for example, that during that part of their menstrual cycle where the estrogen level is low, the medicines don't seem to pack the same punch. And the other thing that I've seen is I was years ago, I was talking with a series of women who would be about 45, 55 years old. And they brought their kids in, and I went through the checklist about ADHD symptoms, and they were saying to me, I didn't have these problems when I was a kid, but recently I've been having a lot of trouble. And it took me a little while, but I finally figured out, well, guess what? Estrogen is one of the primary regulators for the modulation of dopamine in the brain, which is the critical neurotransmitter chemical in the female brain for ADHD. And so what we've done now, we've published 3 studies. My colleague, Neil Epperson, Dr. Epperson works in psychiatry and also OBGYN, and myself and some other colleagues have published now 3 papers that have been published in the journal articles, medical journal articles, about how often women, some of whom have not had any difficulties with ADHD symptoms, experience difficulties characteristic of ADHD when they hit menopause. And we did these studies. The articles describe how we used ADHD medicines with them rather than trying to deal with it with estrogen replacement, which has some problems of its own. And it turned out that in the study, we found that a number of women who had not had a history of ADHD symptoms until midlife, as their menstrual cycle was gradually dropping off the amount of estrogen that was available, were experiencing the midlife onset of ADHD symptoms. And we found that the medicines that we were working with were helpful. If you're interested, the 3 journal articles are available free on my website for the Brown ADHD Clinic. Now back to Dr. Kennedy, please.
Okay. So next is with patient Rory. He's in his late 30s. He's a successful lawyer and having a decent career, but he also gets into trouble at home and thinks of himself as pretty lazy. And what it came down to is he said to me, the medication's helpful during the week when I'm at work, particularly when I'm working alone. But when I'm at home on the weekends, I have most of my work done, so I don't want to get addicted to this medicine either, so I just take a break from it. I hear these a lot, and I talk to people, individually about these sort of concerns. But for him, it seemed like it was becoming an issue over and over again. And the good example he gave me was, on Friday, I promised my wife that I was going to tidy up the house while she was away on business, and I was going to come back on Sunday. But instead, I just played video games the whole time in my pajamas that weekend. And I totally got into trouble with her. She was very upset with me. And it's sort of the same thing over and over again. And he needed, to do something about it. So in that case, symptom control is important on the weekends as well. And also with Rory was addressing some underlying assumptions and fears that he had about addiction and how to take these medications. And that is, under his circumstances, it was perfectly fine to take it, 6-7 days a week, because a lot of the tasks that are impaired in ADHD happen both at home and for people at work too. And for Erica, she was a 15-year-old sophomore in high school. And my title here is, when are 2 meds better than 1? I get pushed back on it sometimes because a lot of people like the convenience of, taking just one thing a day. That's sometimes what people can remember to take. But sometimes having 2 different medications is better. And what she said to me was, my extended release stimulants I tried are better than nothing for helping me focus and remember stuff for school, but I can't take it every day because the side effects bother me too much. And this was on a low dose of an extended release amphetamine. And she had tried a bunch of other different preparations for it, and she was desperate and she didn't want to not take it, but she ended up having to skip it, some days, and that would cause some trouble for her in organizing and studying at school. So what I suggested to her was a little trick I have for some patients where this scenario happens, which is first to take guanfacine extended release for at least 2 weeks and then restart their stimulant. And sometimes that's the restart of the stimulant is still too strong. And in that case, we switch to something different, which I'll bring up in another slide. But for her, in this case, it made a big difference. It made the extended release much more smooth, not as much rebound or any of the side effects that you would see during the onset or duration of it. And for her, there was a lot of the pushback on it was, I'm not hyper, I don't need it. And I was, in the next slide, I'll share some other reasons why it can be helpful for people who are also inattentive ADHD primarily. With Frank, he's a 29-year-old guy, and he's a graphic artist. And he said to me, "Nothing works. I've tried everything." Right. And he gave me a whole list of medications that he's tried over the past, 7-8 years, saying, Vyvanse was too strong or was too weak. And he had tried all the dosing ranges. Same with Adderall. He said that, it kind of helped, but I just was sweating constantly, even on low doses. The Zenzetti, which is a brand for dextroamphetamine, he said that made me feel really agitated. I didn't like how I was on that. Concerta gave me headaches. It didn't work at all. Ritalin, it made me feel too jittery because he had to go on high doses for it to have a response. And he said Quillavant was kind of okay, moderate response, but it was just way too expensive at the time. So what I said to Frank is, hey, have you ever heard of plain old amphetamine? And he looked at me like, yeah, I've had Adderall before. He's like, no, this is a little bit different. This is one of the original Medicaid stimulants that came out as marketed as Benzedrine years ago. And for some people where the rest of these stimulants do not work, sometimes the Avigio or generic amphetamine can work. And like in the previous slide, for someone who's tried a lot of these medications, I'll often have people do the guanfacine extended release for 2 weeks and then start Avigio or the generic amphetamine. Usually I have a pretty decent response for those people. And in some cases, this is another purpose for using the extended release for someone who may have inattentive ADHD. But that's not true for everybody. It's not the sharpest knife in the drawer. It has a moderate effect size for some people, but it does help for some with emotional reactivity and for difficulty falling asleep. But the trick is the timing of it, because it has a 5-hour delay. So if you're someone who has difficulty falling asleep and you're not interested in taking the other prescribed drugs for sleep or for anxiety, guanfacine extended release can help for some. And you want to time it so it's 5 hours before your goal bedtime, and it has a calming effect onset. And my last patient here was Jeff. Jeff, he's an entrepreneur and security software inventor. The question here was, when is it okay to go above the normal dosing range? I hear from, being in a specialist clinic, I hear from a lot of patients of discomfort from their prescribers about going beyond a certain dose, whether it's their age, their weight, or maybe cardiovascular risks, or just lack of experience. But Jeff, I had a great rapport with him. I met with him weekly, and it was for half-hour and hour sessions. And so I really got to know him and understand him. And I believed him in everything he was, telling me for the most part. And he had his wife there in the sessions to help. And I had some feedback from his kids too. But he said, early riser, start work at 7, and I'm home at 6. The problem is that this extended release capsule, which is a new 3-bead thing, is supposed to last all day, but he finds that it lasted until about noontime. And we tried switching up to another extended release or other immediate release, but what ended up happening is doing double of this brand name once in the morning and then once in the afternoon. However, the dose response for him was at 50. And most people who, if they hear, oh my God, 100 milligrams, that's insane. Well, it's not like we started at 100 milligrams. We had certainly started on the low doses and worked our way up to it. And, for a lot of other clinicians, having proper documentation, monitoring vitals and monitoring their health, and, sharing with people what the risk factors are so they're aware. And for some people outside the dosing range, this works. And because of the onset that is about 90 minutes or 2 hours for this particular extended release, we also added in the immediate release Adderall in the morning. And so by the time that was kicking in half an hour, then wearing off there a few hours, then the long acting was starting to work. And it really optimized his schedule. And it had taken him about 8 years jumping through loops with other prescribers to find something that works well for him. He's doing exceptionally well. So these are my cases. I'm going to turn it over back to Dr. Brown.
Thanks, Ryan. And I'd like to emphasize one thing that Ryan is particularly good about, and I think sometimes is a problem that is encountered where other prescribers aren't doing it, and that is the fine-tuning of stimulant medicine. The amount of the dose of medicine for stimulant medicines for people with ADHD does not go by how old you are, how much you weigh, or how severe the symptoms are. It's how sensitive is your body to it. And it's very important for the prescriber to be able to be very careful in trying to follow how a person's reacting to a medicine and realize that bigger doses are not always better and smaller doses are not always better. You're trying to fine-tune it to get that sweet spot between too little and too much. And if you do that, I think what you'll find is that many of the symptoms that we talk about, particularly these inattentive symptoms, which cover such a wide range of cognitive functioning, I'd say about 80% of people who have ADD, whether we're talking about kids or adults, are going to respond. For some, it's huge how much it helps the medicine helps. For others, it's substantial, but not huge. Others, it helps a little, but not that much. And 2 out of 10, it doesn't work very well at all. And you've got to go to other stuff. The numbers I'm giving you have to do with stimulant medicines. We do have a few other backup options if we need to. And usually the adverse effects are transient and not significant as long as these are monitored and the dose is not recklessly prescribed without taking into account this individual. But I think it's also important for us to be careful. We don't talk as though there'll be no problematic effects from medicine. Any medicine you take has a possibility for some people of causing some adverse effects. And we can say that we have an 80% success rate with stimulants, but that still leaves 20% where they don't always work as well. The thing that's critical is for the prescriber and patient to collaborate to get the fine-tuning done. Now, we need to save some time now for questions and answers. I'm just taking a moment to show you these are the books that I have published. The one on the top is a new one about ADHD and Asperger's syndrome in smart kids and adults. It's 12 stories of my work with some children, some teenagers, and some adults who had both ADHD and some autistic symptoms. We know that the term Asperger's syndrome has been taken out of the diagnostic manual, but the fact is that that is a term which refers to a set of symptoms in people who are quite bright, but still suffering from some autism-related impairments. So those are some additional resources that you can check out if you want to get more information about these things. All of these are available on Amazon. But let's stop at this point because I'm interested to hear what questions people have raised.
Thank you, Dr. Brown and Dr. Kennedy. That was really so much there. We have literally hundreds of questions. So let me see if I can group them a little bit. Let's start with diagnosis. A couple of listeners have commented that it's very difficult to be diagnosed, and specifically they feel that girls or women with specifically the inattentive type of ADHD seem to have a tough time getting diagnosed. Do you have any advice for finding a practitioner? Is there a screener that can be used in school settings? What is your advice to those who believe they have inattentive ADHD and are having a hard time getting an accurate diagnosis?
Okay, I guess we're both waiting because I'm not sure which of us you wanted to respond. But what I can tell you is that if you ask your primary care doc, sometimes they know people in the community who are pretty good at this sort of thing, because a lot of physicians, even some psychiatrists, have had very little training to refine their skills for dealing with ADHD. And the other thing you might look at is, Attitude Magazine has its list of resources, and CHAD has a list of resources of people who are available in different parts of the country to provide these services. And generally, what we do is we've got, we do an intensive interview with people, but we also use normed rating scales so you can compare the specific behaviors that are problematic for people, their troubles with inattention, as well as any other behavioral problems that might be involved. So you can see then if you add up the scores on this, particularly if you can get self-report and also report from somebody else who knows the person well, a parent or a friend or a spouse, to take a look at those norms, that'll give you some idea of how much these issues that are being talked about are like the profile for somebody with ADHD.
And for some adults that come in by themselves for an eval, it's really helpful when they have sometimes a parent or a sibling can jump on the phone just to fill in some information or even fill out a rating scale for us. But having teacher reports from elementary school or middle school, just to find a trail of the history of ADHD. And that usually makes, clinicians feel more comfortable with accepting and acknowledging that there may be an attention problem.
Okay. Any specific advice in terms of, someone mentioned specifically neuropsych evaluations?
Yeah, I've got a strong reaction to that. I think that neuropsychological evaluations are not necessary or even helpful, usually, for assessing for ADHD. It's a battery of tests administered by a neuropsychologist in an office setting, which is focused on these things that are called so-called tests of executive function. And they're very good if you're trying to see if there's been damage from a stroke or from a head injury. They are not good at evaluating the various activities of daily life that people have to engage in, which is where you really see the difficulties of ADHD. So in my mind, that's an expense and a task that's not necessary and not helpful. But what is needed is to have a clinician who knows what ADHD looks like and what, how it's typical, what's difficult and typical for people of a particular age, and to be able to compare it with that. Somebody who knows ADHD, knows other things that are often comorbid with it, and who takes the time to be able to ask enough questions to really get a clear picture of daily functioning, which is not what you pick up in a neuropsych report.
Mm-hmm. I think that's really an important point. We have a great article on attitudesmag.com, by the way, listeners, by Dr. Brown about diagnosing ADHD and the different reasons neuropsychs, just as he described, don't pick up the key issues. Here's a person who says he's recently been diagnosed with bipolar disorder and autism spectrum, but really feels like they probably have inattentive ADHD. The assessments and questionnaires seem to miss the way you describe it in your model. How can someone like me get a correct diagnosis? And the comorbid questions, I think, are difficult for many of the listeners.
Well, and they're difficult for a lot of clinicians because many prescribers, and including psychiatrists and psychologists, often have not had refined training about ADHD. And for example, with an adult, they have 6 times the likelihood of having another diagnosis along with ADHD, if you look carefully. Mm-hmm. Very often there may be bipolar disorder, there may be depression, there may be anxiety, there may be substance use issues. And it's really important to be dealing with a clinician who knows what these other things look like too, and who can sort them out and see, because sometimes, somebody thinks, this is bipolar disorder, when it's somebody who just has particularly hyper ADHD.
Right.
And other times it might be classified as just depression, when in fact it is ADHD and a bipolar disorder.
Right.
This is like Dr. Brown says, that people don't come into our office with labels on their forehead. And sometimes we don't know the first time we meet someone, but sometimes we do after several sessions, and we pick up on a pattern. And at that point, if it makes sense, you can bring it up, because maybe clinicians are apprehensive about it or not sure, and having a second opinion can be helpful. But the treatment for it can be very unique for that sort of individual with Asperger's, ADHD, and bipolar, depending on what type. But having a specialist, I think, would be a good place to start.
That makes sense. Another diagnostic question: what about how are you able to distinguish between anxiety and ADHD?
Anxiety is a very common thing. For example, with kids, the prevalence of anxiety disorders in children is, in the general population, is about 5%. Among kids with ADHD, the prevalence of anxiety disorders is about 35%. Many of these other psychological and psychiatric disorders, and also incidentally learning disorders, which are often neglected, are far more common in people with ADHD than they are in the general population. And we could talk about what that has to do with the way the brain works, but for practical purposes, I think it's just important to be able to seek out a clinician if you've got a thing that's puzzling and it's not working out, to find a clinician who's a specialist in this and who is familiar with all the various presentations that often go along with ADHD, because very often it's ADD plus.
Right.
Usually in our evaluations, one of the questions we'll have is, do you worry more than most people your age? And then we ask for some examples. And from there, we can open it into maybe there's a rating scale that would help explain more, or just having more examples of what they're talking about.
Yeah, and I think that also underscores the importance of having the evaluation involve enough conversation that you can actually get to the details.
Mm-hmm. Okay.
Now, in our clinic, we have the luxury of spending 3 hours for an initial evaluation. And there are many places where that's not possible because of the cost and the availability of staff time. But the fact is, it does take some time to do a serious evaluation and get a clear picture, particularly when it's complicated by other disorders as well.
We have a number of listeners who are talking about being diagnosed in their 50s and their 60s, and even an 81-year-old. Are there any special issues related to being diagnosed, let's say after 60? Well, yeah,
it's nice if the person who's doing the evaluation is familiar with how ADHD looks in people who are in their 50s and 60s. But the reality is, yes, there are some people who have lived with ADHD for all their lives and have thought, well, I'm just sort of lazy, or I'm just not very well motivated, or I worry too much. And sometimes it's not until their grandchildren are diagnosed that they think, some of these things really do fit with me as well. And we do now have some research which is accumulating that shows that many of these patients, are people who can benefit from the same treatments we use with people who are much younger.
Are there any, some listeners have said that they've been told they cannot take stimulant medications because of age or hypertension or heart issues? Are there specific challenges to treating people who are older?
Well, if you're treating somebody who, regardless of age, who's got cardiovascular problems, you've got to be very careful about this. And we would, in that situation, want to consult with a cardiologist to see about what is safe and what is not safe for them. We do have some non-stimulant medications which do not impact blood pressure particularly. But those are things that need to be evaluated. But it's also true that many adults in their 50s, 60s, and 70s have ADHD. It causes difficulty for them, and they need medication. Now, it doesn't necessarily mean that they need medication throughout every single day, every day of the week. Now, they sometimes need it for specific tasks they have to do. But those are we need to, one of the things that we ask of everybody is that they, before any prescription is going to be forthcoming from our clinic, is that they get a physical examination from their primary care doc.
Within the past year, at least.
Mm-hmm. Yeah, within the past year, to be sure that we've taken account of any particular risk there might be in the treatment.
And even if someone has a heart murmur or an arrhythmia, it wouldn't automatically disqualify them from having stimulant treatment, but the clinician should be cautious and, follow protocol of having a cardiology consult. And if you have clearance from them and you feel comfortable prescribing them carefully, monitor them closely, and I think you can make a treatment plan with a stimulant. But, it's each individual has their own unique response to these medications. So it's something that's important, to discuss with your prescriber.
Your comments about menopause and estrogen prompted a lot of interest. Couple of questions specifically. Are postmenopausal women with ADHD more likely to experience other brain function issues, dementia, Alzheimer's? We probably don't know that, I would imagine. But
the dementia and Alzheimer's are different processes. But what we can say is that menopause for all women involves a significant decrement and chronic decrement in the amount of estrogen, and that estrogen happens to be one of the primary modulators for the release of dopamine in the female brain. And we've certainly seen and have demonstrated in several research studies and that have been published in medical journals, copies of which are available on my website, that some of these women who have midlife onset of ADHD type symptoms, though they may not have had any history of this earlier in their life, do experience difficulties that look an awful lot like ADHD and which can respond in many cases to treatment with the ADHD medicines we regularly use.
Okay, yeah, makes sense. Oh, here's an interesting question. As far as estrogen, menopause, and ADHD, is the same thing true for men with testosterone declining?
We don't have data on that right now.
Mm-hmm. What's your guess? I guess you can't guess. You're a scientist.
But the other thing that needs to be said is that often it depends on the tasks you're experiencing. If there are many people who, for example, I've had a number of people who have jobs where I'm thinking, for example, of an intensive care nurse who got appointed to be the charge nurse and then the senior nurse for running a whole unit. And she was doing fine as long as she was just taking care of the 2 or 3 patients that were assigned to her as a line nurse. But when they added administrative responsibilities to it, that's the place where her ADHD really got in her way. And there are some people, as you get older, and for example, if you're taking on responsibilities of carrying on a full-time job and managing children, and the demands that it makes on your time, and it's not just when they're little kids, it's also when they're adolescents. If you change the job description, it's quite possible for somebody with ADHD to function pretty well as long as it doesn't get pushed into these additional management responsibilities. And that's the point where you begin to see, these ADD things really are a problem and it needs to be addressed.
Right. That, people do wonder, estrogen aside, whether aging is associated with symptoms becoming more difficult. So this person says, I was diagnosed at age 65 and concluded that aging made my symptoms much more pronounced. And another person...
Well, it does. And I can tell you that, for example, I have trouble sometimes in recalling the name of a medicine that I'm used to talking about daily. Mm-hmm. And I think most of us, as we get a little bit older, find that some of our memories remain very much intact and very accessible. And then sometimes names of objects or persons or processes become quite elusive that you used to be able to manage. The aging does have an effect on it, on all of us. Right. And it's in different ways for different people. But I think that does not mean that it's impossible for us to provide some help. We can't change the structure of the brain, but if the brain is having some difficulty with ADHD type symptoms, it's possible we might be able to address it with medication.
Okay. Flurry of questions from people who are looking for non medical treatment of ADHD. So, for example, is there any evidence-based, non-pharmaceutical, non-stimulant treatment for improving focus in adults? One question, or a similar question. My daughter and I have inattentive ADHD, and we are looking for a non-prescription solution.
Okay, well, you can be looking for a non-prescription solution, but the reality is there's not much you're going to get that is scientifically demonstrated to alleviate the symptoms of ADHD. The
one
simple
exception, maybe in the. Sorry, I'm cutting you off.
Well, let me just finish what I was trying to say. That there certainly are ways in which medicines are not going to fix everything, and some people where they just don't work. And but the fact is that there are, and I don't think most of the people we see need some help besides just medicine. It's not like pills are going to teach skills. This is not a situation where medicine fixes everything, but if you look at the scientific evidence about the effectiveness of most of the treatments proposed for ADHD, whether it's changing a diet or adding some new nutritional compounds or something like that, the evidence for this does not hold. And it just is not very impressive. Like you can treat pneumonia without medication, but the fact is it doesn't usually work out very well.
Would you, in a case where someone really cannot or will not take a stimulant medication, would you recommend coaching, or are there other cognitive behavior?
Coaching can be helpful, but the fact is, if the issue is how the person's brain is operating, the coaching isn't going to change the chemistry of the brain. And ADHD is fundamentally a problem in the dynamics of brain chemistry. And if you're going to make an intervention that's going to make much of a difference, coaching can help, sure, with the right coach and the right set of tasks that you're trying to deal with. But if you're trying to change how the brain chemistry works, there's not much evidence that shows that anything other than medication is going to be very substantial in its impact. Okay.
All right. A last question, which is a little bit on the humorous side, maybe not if it's the person who wrote it. And this is about living with ADHD, with people with ADD and ADHD. As a spouse of someone with ADD, how do I address the uninterested aspect? Just because this person has ADD and is not interested in managing household tasks, bills, doctor's appointments, doesn't mean they shouldn't be responsible for these things. How does this get addressed? So this is...
I think most people in relationships of marriage or even just living with somebody find ways of letting people know that if you're not willing to carry your share of the weight, I'm going to make you feel it. ADHD is not an excuse for taking some responsibility for what needs to be done in a household or in a job.
Right. Okay. With that note, let me thank you both for an extremely interesting presentation, and all of our listeners for joining us today. Don't miss future Attitude webinars, our expert articles, research updates. You can sign up to receive our free newsletters at attitudemag.com/newsletters. So thanks, everybody, and have a great holiday weekend coming up.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.